Okay, so now we'll begin our lecture on patients with pituitary and adrenal gland problems, and this is chapter 65 in your Iggy book. So to begin, we'll talk about disorders of the anterior pituitary gland. And so as you see here, you see that when we talk about disorders of the anterior pituitary, it can be either a primary pituitary dysfunction or a secondary pituitary dysfunction. And so if it's a primary problem, then it's a problem with the actual organ itself. And so we learned during our first lecture all of the different organs that that the pituitary gland affects. So again, with a primary problem, it can be a problem with the actual organ, and then with a secondary pituitary problem, it's a problem with the hypothalamus. And so in either case, whether it's primary or secondary, the person will have hypofunction or hypofunction depending on whether the hormones are undersecreted or oversecreted. So first we'll begin with talking about hypopituitarism. And as it says here, it's a deficiency of one or more of the pituitary hormones and results in metabolic problems and sexual dysfunction. When we talk about panhypopituitarism, it's a dysfunction, well, it's decreased production of all of the anterior pituitary hormones. So if you'll remember our little sentence, man to a 10, Lawson feels pretty good. All of those different hormones that we learned about that are secreted by the anterior pituitary gland, well, if it's panhypopituitarism, then the person will have a decreased production of all of those hormones. The most life-threatening deficiencies are when a person's ACTH, their adrenocortical hormone, and their thyroid stimulating hormone falls to really to low levels. And so more commonly than anything else, there's a decrease in the secretion of one hormone and a lesser decrease in the other one. So what you'll find with hypopituitarism, that you'll have one of those hormones that's really low, and then the others may be slightly low, but you'll have one that's extremely lower than the others. So some causes that we see of hypopituitarism may be tumors, anorexia nervosa. Anytime we see shock or hypertension and the person is in the brain is not being perfused sufficiently. Head trauma, where there's damage to the hypothalamus and subsequently the pituitary gland. Infections, anytime we talk about meningitis, an infection of the brain tissue itself. Sheehan syndrome is also known as Simmons, SIMMONDS syndrome. Or it's also referred to as a postpartum hypopituitarism. And so with this, the person develops necrosis of the pituitary gland after pregnancy. And so when this occurs, the person is going to have decreased function of the pituitary gland, and so it's often caused due to blood loss or hypovolemic shock that can occur after the person goes through childbirth. So the person has the baby, they can't control the bleeding, and the person and that woman loses a lot of blood. It can lead to Sheehan syndrome or Simmons syndrome, where that underperfusion of the brain causes necrosis of the pituitary gland. So with our collaborative care, first with our assessment, we're going to ask the person if they've noticed any changes in their sexual hormones, any changes in reproduction, in sexual arousal. Have they noted any changes? And when we talk about interventions, well, we're going to replace the deficient hormones. If the person has gone through virilization, then the treatment is going to be high doses of testosterone. until there's the presence of male secondary sex characteristics. When we talk about replacing hormones, though, gynecomastia can occur. If this is the woman, we can give estrogen and progesterone therapy. And if the person has a decrease in growth hormone, well, then we are going to give the person exogenous growth hormone, or somatostatin. So with hyperpituitarism, we just talked about hypo, but with hyper, this is when hormone oversecretion occurs with pituitary tumors or hyperplasia. There could be some genetic considerations. Also, the person could have a pituitary adenoma, so a tumor that actually affects the pituitary gland itself. And so once our epiphyseal plates close, the epiphyseal plates are related to our bones. They're at the end of our bone plates. And so once the epiphyseal plates close, as we grow older, we no longer grow taller. So when a child has a problem with growth hormone as a result of hyperpituitarism, before the closure of the plates, the oversecretion caused the child to increase in size. And so this is where we see the gigantism that occurs. The inverse is true if we're talking about hyposecretion with the person that has hypopituitarism. Then the person's growth is going to be stunted. So back to hyperpituitarism. If the person has increased growth hormone before puberty, then we call that gigantism. If the person has an increase in growth hormone after puberty, then we call that acromegaly. And so growth hormone in the adult affects the small tissue, the soft tissues, and also the bones. And so what we'll see when a person has an increase in growth hormone as a result of hyperpituitarism, well, then they have soft tissue changes, and the changes in the soft tissues may be reversible, but the skeletal changes are not going to be reversible. They're permanent. And so what happens is that the person has skin thickening, hypertrophy of the skin. They can also have enlargement of organs such as the liver and the heart. And so this picture is in your book. It's just showing you an example of a person that has gigantism. And gigantism is what occurs when the person has growth hormone hypersecretion before puberty. So really large children or teenagers. And acromegaly, there's a picture in your book, but acromegaly again is what happens after puberty has occurred. And so this is when we have an increase in the soft tissues, and it can also affect the skeletal muscle. So again, our non-surgical management can be done with drug therapy. We can give the person dopamine agonists, and we give dopamine agonists because they inhibit the release of many of the pituitary hormones that we've learned about. Okay, there's also radiation. Radiation can be done to stop the secretion of the pituitary gland, but the inverse of receiving radiation therapy is that it can cause the person to develop hypopituitarism. So surgical management of hyperpituitarism is removal of the pituitary gland. And so this procedure is demonstrating a transsphenoidal hypophysectomy. And so with the transsphenoidal approach, an incision is made above the upper lip, as you see here, and the pituitary gland is removed through the sphenoid sinuses. Other ways that this procedure can be performed is through a craniotomy, where they're actually making an incision in the skull and removing the pituitary gland. Well, this procedure is minimally invasive, and it can be done within an hour. I've posted for you on the next slide. This is a YouTube link that I would like for you to watch, and it just explains the transsphenoidal hypophysectomy for you. When we have a patient that has had this procedure done, it tells us a lot of things that we want to do in the postoperative period. Definitely we want to monitor the person's neurological response. We saw from the previous slide that this is an actual incision into the brain, and so we have to monitor the person's level of consciousness. We're looking for changes in the level of consciousness. We're also monitoring the person for a cerebrospinal leak. So what we'll put the person on is a mustache drip pad, and so the reason we're putting that there is because the person is going to have drainage, but we want to monitor the person for a cerebrospinal fluid leak. And so what we're going to do is we're going to assess that nasal drainage on that mustache pad, and so mustache drip pad, and so we're looking for what we call a halo sign. And a halo sign is when you have clear drainage, but it has a yellow outline. And so when this occurs, then we know that the person has a cerebrospinal fluid leak, because the glucose is what's causing the halo to occur, and you have glucose that occurs in cerebrospinal fluid. If the pituitary gland is removed, the person is going to be on hormone replacement and glucocorticoid replacement for their entire life, the remainder of their life. We want to monitor the person for signs of meningitis, and so these signs would include a headache, fever, a stiff neck, and so we want to definitely report those things. When a person develops a cerebrospinal fluid leak, it can be resolved with bed rest. So we, in the postoperative period, we want this person to remain on bed rest. We want this person to avoid bending, avoid straining at the stool. Also, this person is to try to avoid coughing and sneezing, blowing the nose, brushing the teeth, because all of these things can increase intracranial pressure. Okay, so as I just said, persons avoid brushing the teeth. The person may experience numbness in the incision area, and definitely they may have some decrease in smell. So we want to make sure we're teaching them all of these things prior to the procedure, just so they don't, think they're having a complication after they've had the procedure. So the person, it may take maybe 2 weeks for the incision to heal. We want the person to avoid brushing the teeth so that they don't disrupt the sutures, but they may be able to use toothpicks. The numbness and decrease in smell, this is common, as I said, for up to 3 or 4 months. We just want to make sure we're educating them and let them know that. Vasopressin is going to be needed because the pituitary gland is moved, and so they're going to need the vasopressin to help with fluid balance. So diabetes insipidus, as it says here, is a water metabolism problem caused by an antidiuretic hormone deficiency. So either the person has a decrease in ADH synthesis, or they have an actual inability of the kidneys to respond to ADH. And so diabetes insipidus is classified in these ways: nephrogenic, primary, secondary, or drug related. And so diabetes insipidus is a disorder of the posterior pituitary gland. When a person has this disorder, the person is losing too much water. Thirst prompts water intake, which aids in maintaining fluid balance. If the person has a poor thirst mechanism, then they're at risk for dehydration and death. The person can have an inherited actual problem with the kidney, and so that's when we would have maybe it's a nephrogenic problem. A primary problem would be, again, when there's a problem with the pituitary gland itself. A secondary problem would be tumors that are near the hypothalamus or the pituitary gland. And also, drugs can cause diabetes insipidus. Lithium is a drug that affects the abilities of the kidneys to respond to ADH. So again, diabetes insipidus is a disorder of the posterior pituitary gland. With this disorder, the person is losing too much water. Okay, so with assessment of this person, most of the manifestations that we see with diabetes insipidus are dehydration. The kidneys are not responding to ADH, so the person is going to have an increase in the frequency of urination. They're going to have excess thirst. So again, it's kind of like what we see with the person once they develop diabetes. The increase in thirst, the increase in urination. There are tests that can be done. A dehydration and hypertonic saline tests are used to help diagnose the disorder, to see if the person is retaining any fluid as a result of the hypertonic salines that are given. What we notice when we test this person's urine is that it's going to have a very low specific gravity, which means that it's not concentrated at all. It's very dilute. So the interventions that we use for diabetes insipidus, you see desmopressin acetate. Another name for that is what we call vasopressin. And so this can be given orally or it can be given intranasally. And so the person is going to require lifelong vasopressin therapy. And we want to teach the patients to weigh themselves daily to identify if they're experiencing any weight gain. All right, so the inverse of that, syndrome of inappropriate ADH, this is when vasopressin is secreted even more, even when the plasma osmolarity level is low or normal. And so with this syndrome, the person is retaining too much water. So some reasons that we see syndrome of inappropriate ADH occur. It can occur because recent head trauma. This is probably if the person has damage to the hypothalamus, cardiovascular diseases, tuberculosis and other pulmonary diseases, cancers, drug use. All of these can cause syndrome of inappropriate ADH. And so what we do to treat this person is, first we're going to restrict the person's fluids because they're already retaining too much fluid. So we're going to give the person diuretics, hypertonic saline. This is used only in severely symptomatic patients. We can give this if the person has severe hyponatremia, because if you think about it, the person is retaining too much fluid, and so it's going to cause the sodium that they have to become dilute, so they may need a hypertonic saline solution. We're going to monitor this person for fluid overload. We're going to monitor them definitely for congestive heart failure. Also, we've got to make sure that we're listening to the lung sounds, monitoring the person for pulmonary edema. We want to make sure that the person is in a safe environment. If you'll remember about sodium and the effects of sodium, it can cause some neurological changes, changes in mental status, and so we want to make sure we're assessing the person's doing a neurological assessment, because they're retaining so much fluid that it can cause the brain to swell. So the meclocycline is a medication that can be given, and it's supposed to block the ADH receptor hormone in the brain. So this is a med, again, that can be given to block the effects of ADH. So when we talk about adrenal gland hypofunction, this is when the primary cause of this can be actual damage to the kidneys. We talked about the adrenal gland, and it is located on the kidneys. So a primary cause is when there's actual damage to the kidneys and they're unable to respond to the stimulation that comes from the pituitary gland. A secondary cause would be problems with that pituitary gland or the hypothalamus. And so if you'll in your book, there's a chart that tells the primary and secondary causes of adrenal insufficiency. So you may want to make sure you pay attention to those listed on page 1382. But when we have a patient that has primary insufficiency, ACTH, or adrenocorticotropic hormone, and MSH, or melanocyte stimulating hormone, these levels are going to be elevated, and they're going to be elevated because they're attempting to stimulate the glands, but they're not responding because of whatever reason, because those glands may be broken, maybe there's tumors developed, but for whatever reason, the pituitary gland is giving the stimulus to release those hormones, and so, as I said, the levels are going to be high, but the gland is not responding to it. It's not taking the stimulus. And so the effects of insufficiency of adrenocorticotropic steroids, well, the person is going to have a loss of aldosterone and cortical action. And so the person is going to have an impaired ability to manufacture glucose. So when a person does not take in food, the body has a way of developing glucose within the body so that hypoglycemia does not occur. Remember, we have the liver that converts stored glycogen into glucose, also known as gluconeogenesis. Gluconeogenesis is when amino acids are converted to glucose. However, when there's a deficiency of adrenocorticotropic steroids, these processes cannot take place because the body loses its ability to manufacture glucose. Aldosterone is the hormone that aids in fluid balance by causing sodium and water retention and potassium wasting. And so what we see in the absence of aldosterone, water and sodium are going to be lost, and potassium is going to be retained. Also, the person is going to have an increase in hydrogen ions, which leads to acidosis. In addition to those things, the person is going to have impaired androgen. So remember that our adrenal cortex is responsible for sugar, salt, and sex. So we already talked about impaired manufacturing of glucose. The aldosterone is the salt that we talk about, and then the person is going to have impaired androgen production, and so the person may notice a decrease in body and axillary hair. So some primary causes that we may, the person can have a primary cause of Addison's disease, or they can have a secondary cause. And the secondary cause is when the person has a sudden cessation of long-term high-dose glucocorticoid therapy. Or basically, this is when the person abruptly stops taking steroids. And so if any of you have ever been on a Medrol dose pack or any type of steroids, what you'll notice is that they taper you off of steroids. It's not an abrupt stop. They taper you off. The first day you may take 4, then 3, then 2, then 1. But it's not an abrupt stoppage of those medications. When that happens, it can throw the person into what we call Addison's disease or Addisonian crisis. And so again, Addison's disease is when the person has adrenal insufficiency. This is when a person has a crisis that develops. It is a life-threatening event in which the need for cortisol and aldosterone is greater than the available supply in a person's body. And this usually occurs, as it says, as a response to a stressful event. The stressful event triggers the release of cortisol and aldosterone. And so anytime we have a stressful event, it naturally triggers aldosterone and cortisol. Well, what happens for this person, the reason it's life-threatening is that it's triggering this response in a person that's already deficient. And so what happens as a result of this is that it leads to severe hypotension due to the lack of aldosterone, and then the person has the elevated potassium, and it's going to lead to cardiac dysrhythmias. The person can also develop a hemoconcentration. This occurs due to the lack of fluid. They're not retaining enough fluid, and so the person has a thickening of blood. And so when we do blood draws on this person, it appears that they have a elevated hemoglobin level. And so the treatment is going to be hormone replacement. The person is going to need hydrocortisone, which is a glucocorticoid, fludrocortisone, and that's spelled FLUDRCORTISONE, and that's a mineral corticoid. And this medication is going to help with the potassium and sodium balance. And cortisol functions to increase glucose levels through gluconeogenesis. And so again, gluconeogenesis is when we have glucose that's made from proteins or amino acids. And so I have a note here. When exogenous steroids are used with patients, and so exogenous steroids are pills that we take from the outside, your things like your prednisones and your solumedrols. Patients will have to have their blood sugars monitored. So the patient may say, but I'm not diabetic. What we have to understand as nurses is that steroids promote the manufacturing of glucose, even when the existing glucose levels are normal. Steroids by nature will cause the person to produce more glucose. And so when we give a person steroids, they may experience elevations in their glucose levels. And so this is why we we'll do blood sugars or monitor pattern blood sugars on a patient when they're receiving steroids, because it's just what happens naturally in the body. You give a steroid and a person produces more glucose. So with our assessment of this person that has hypofunction of the adrenal cortex, we're going to monitor them for hypoglycemia. We know that the sugar hormone has been affected. The person may have some pigmentation changes because that melanocyte hormone has been affected. They may have some GI disturbances. Remember when we did our lecture on the GI system, and I talked about potassium being plentiful in the GI tract, and it causes smooth muscle contraction. Well, this person is going to have a lot of potassium, so it may cause some GI disturbances. The person may have some weakness, they may have weight loss, and they may have some hypotension. Now, when a person has adrenal gland hypersecretion, we call this Cushing syndrome. The person may have hyperaldosteronism or excessive androgen production. And so again, this is a condition where the adrenal cortex is impaired. Causes include kidney problems, problems with the anterior pituitary gland, the hypothalamus, and this can also be caused from the use of exogenous glucocorticoids or steroid treatment. And so these things lead to hypocortisolism. Okay, excuse me just a second, I need to get to the correct slide. And so hypocortisolism, or what we call Cushing's disease, this is a disease when the person has an oversecretion of ACTH by the pituitary gland. It can be an actual problem if it's the adrenal cortex, and so this is when the person is going to have an oversecretion of glucocorticoids. The most common cause is pituitary adenomas. And so what we're going to see in this person is that they're going to have excess sugar being released, and so this excess of sugar is going to affect metabolism. The person may report to you that they've had some weight gain, increases in their appetite. They may have an increase in fat. Sugar causes the retention of water, and so the person develops a truncal obesity. They may also develop a buffalo hump, which is what you see here on this guy. This increase in soft tissue in the back of the neck. And so the person may also have problems with immune function, and so excess cortisol, which is a steroid, causes an excessive anti-inflammatory process which suppresses the immune system. High doses of cortisol kills the lymphocytes, the eosinophils, our macrophages, and our cytokines. And so those are examples of our white blood cells that are our fighters. And so high levels of cortisol are going to kill those. So again, they're going to affect our immune function and the person's ability to fight off diseases. When the person has elevated androgens, it's going to lead to acne, hirsutism. Also, Cushing's disease can lead to thinning of the bones, or what we call osteoporosis, which can eventually lead to fractures of the ribs, long bones, and the spinal vertebrae. The person may also have glucose intolerance. And so when a person has excess cortisol, it causes elevation in the blood glucose levels. And so people that have Cushing syndrome may develop glucose intolerance, which is a pre-diabetic condition that can progress to diabetes mellitus. It can affect the cardiovascular system because the person may develop hypervolemia, which is going to lead to hypertension. And so in your book, it should go over some of the causes that you see when a person has cortisol excess. And so when we do a psychosocial assessment on this person, they may report that they're irritable, confused, they have mood swings. The labs will show that the person has high cortisol levels. The ACTH levels are going to be elevated in the person that has pituitary Cushing's disease. And so imaging assessments may be done to look for lesions. The tests that can be done, one or more of the following can be done. Measurements of cortisol can be done with the 24-hour urine specimen. And so with a 24-hour urine specimen, we're keeping up with all of the person's urine output for 24 hours. And again, that's to measure the cortisol levels. A blood or saliva test can be done to check for the rise and fall of cortisol levels. And so the test may require collection of blood or saliva late at night. And then a low-dose dexamethasone test can be performed. And so low doses of dexamethasone are going to suppress cortisol production in a healthy person, but not in those with Cushing syndrome. So when we talk about patient safety, we want to monitor this person for infection because they're at risk for infection. Remember, we talked about the macrophages, the eosinophils being suppressed because cortisol suppresses those, and it has an anti-inflammatory response that suppresses the immune system. The person is at risk for hypervolemia, which places them at risk for cardio complications such as congestive heart failure. The person may also be at risk for pulmonary edema, so we want to monitor the lung sounds, monitor the person for increase in respiratory effort. Nutrition, when we talk about nutrition therapy, we definitely want to decrease this person's sugar, increase protein because the protein stores are going to be depleted. We also want the person to be on a fluid restriction. We want to monitor the person's salt. They may be on a no added salt diet. When we talk about drug therapy, mitotane, which is spelled mitotane, is used for adrenal tumors. It decreases cortisol production. Elliptin, which is spelled ELIPTN, is a medication that interferes with ACTH production and is useful in people that actually have pituitary problems. But again, we want to monitor the person for cardiac complications, monitor them for infection. We want to monitor the person daily because this is the best indicator of fluid retention. So again, the person that has hypercortisolism, they may have a hypophysectomy performed. We already talked about the transsphenoidal hypophysectomy that can be performed, and adrenalectomy if it's a problem with the kidneys. So with hyperaldosteronism, this is when a person has increased secretion of aldosterone, which results in a mineralocorticoid excess. The person may have primary hyperaldosteronism, which is also referred to as CONT'D disease, and it results in excess secretion of aldosterone from one or both adrenal glands. So when a person develops hyperaldosteronism, they're going to have hypernatremia, hypokalemia, and metabolic alkalosis can occur. Definitely if the person is retaining sodium, it's going to increase the blood volume, so the person is going to have an increase in the blood pressure. When the person develops this, they're at risk again for heart failure. Strokes can occur, heart attacks, and the person can also develop kidney damage. Then in addition to that, the effects of the hypokalemia can cause life-threatening dysrhythmias as well. So the most common issue that we see, the most serious issue that we're going to see with hyperaldosteronism is the hypokalemia and the elevated blood pressure. So the person may need, if surgery is not done, the person may need potassium supplements, possibly spironolactone, which is a potassium sparing diuretic, because the person is retaining fluid, so we want to give the person a diuretic but a potassium sparing diuretic. Other things that can be done for this disorder is adrenalectomy, drug therapy, definitely with glucocorticoid replacement. When surgery cannot be performed, again, the person is going to be started on spironolactone therapy. With PHEOCHROMOCYTOMA, this is when the person has hyperstimulation of the adrenal medulla. It may be caused by excessive secretion of catecholamines. And so what we have here is that the person has epinephrine and norepinephrine that's being released, and it's causing an increase in the blood pressure and also the heart rate of the person. And so surgery is going to be the main treatment that's done for pheochromocytoma. The person may have one or both of the adrenal glands removed, depending on whether the person has a tumor on both kidneys. And so again, hypertension is going to be what we typically see when a person has pheochromocytoma. So we have to make sure that we're monitoring the person's blood pressure. It tells us that the person should not smoke. They should also avoid caffeinated beverages and to change position slowly. But again, the treatment for this may be removal of the adrenal glands.